Welcome everybody to another edition of Question Lab. Tonight we're going to be tackling the reproductive system, and as always, our co-host is Dr. Paris Vicaria. So, Paris, would you mind introducing yourself to the crowd tonight?
Yeah, thank you, Jeff. Hey guys, my name is Paris. I am a dermatology resident here in Dallas, Texas. I originally graduated from pharmacy school and then went back home to Michigan to complete medical school. I'm also an RX coach with USMLE-Rx, so I work one-on-one with students such as yourselves to help prepare you guys for the USMLE Step 1 and Step 2 CK as well. And I'm happy to help lead tonight's session.
Excellent, thank you, Paris. And we've got a couple of coaches with us, and I'm going to give them a chance to introduce themselves as well. So first off, I'll start with Brenda. Would you introduce yourself?
Hi everyone, my name is Brenda Mariano. I'm a third-year medical student here at Central Michigan University. I wrote my Step 1 last year, and I used a lot of the RX resources to help me succeed. So hopefully I'll be able to coach one of you guys one day. And I know Step 1's pass or fail, but the knowledge passes on to Step 2 in the shelf exam. So please put the time into it, and hopefully I'll be your coach.
Excellent, thank you, Brenda. And we have another coach with us, Brian Smith. Brian, would you introduce yourself?
Yeah, thanks, Jeff. Good evening, everyone. My name is Brian Smith. I am a current ophthalmology resident in Philadelphia, Pennsylvania, and I work as an RX coach to work one-on-one with you to help meet your goals of crushing Step 1 and Step 2, as well as the complex exams. I'll be helping answer questions in the question box tonight, so feel free to ask away.
Okay, thank you so much. So you've had a chance to meet us. We also have Kate in the background here helping to answer your questions, but it's only fair that we get a chance to meet you as well. So what we're going to do is we're going to open up a poll. Now, if this is your first time joining Question Lab, the polling mechanism here is the same that we use for answering questions. So what I'm going to do is I am going to open up the first poll of the evening, and this is going to be your easiest question of the night. Who are you? So select the option that is closest to you, whether you're an M1, M2, M3, M4, or if you're an IMG or FMG. Go ahead and make your choice. Typically what we do is we'll wait until about 2/3 of you have voted before we close the poll and share the results. So it looks like we have reached that threshold, so I'm going to go ahead and close the poll. And let's share those results. So looks like we've got a pretty strong IMG, FMG contingent, almost 7 out of 10 of you, as well as some M2s and M3s, and even a few M4s, and maybe a couple of M1s. So thank you for all of you for joining in, and we hope that this is going to be a helpful session for you. I'm going to hide those results now. Just as a reminder, we will have a raffle at the end of the event. You do need to be around. You need to still be logged in order to win tonight's raffle prize, which will be a subscription to RX 360 Plus from USMLE-Rx. So let us, we're going to go forward here and get started. You've met 3 of the members of the RX Coach team, and we're going to talk a little bit more about RX Coach later on in the evening, but really just want to let you know that what we're going to be doing tonight as we dissect questions and as we break them down, we're really going to be following the same methodology that we have devised for RX Coach. So as you go through this, especially if you're new to, board style questions, or maybe you're just really starting to get serious, this will give you a bit of a sense of how we advise our students to break down questions. Okay, so with that, let's go and answer question number 1. Now, there is a slight difference when you see the questions as we present them here. You see that there's no answer choices, and this is by design. We advise our students to cover up the answer choices first, and we do that as basically as a way to help you stay focused, so that you don't get distracted by a distractor, a phrase, a term, a drug, something that you don't recognize or something that you don't know very well. We find that can be jarring and can, knock you off your stride. So what we recommend in our methodology, you read the lead in first, and the lead in is the actual question part within the item. And then we say, go back and read the vignette. And it's after you've done that, then we uncover those answer choices after we've really analyzed the information presented here. Okay, so that's how we're going to do it. So again, we start with the lead in. Which of the following is the most likely finding in this patient? Think about what kind of information you should be seeking out as we read the vignette. A 17-year-old boy is brought to the clinic because he has not developed signs of puberty and has behavioral problems at school. He has erections but does not ejaculate. Vital signs are normal. Physical examination shows a tall height for age, no body hair, small penis, small and firm testes, and mild gynecomastia. The prolactin level is normal, and luteinizing hormone and follicle-stimulating hormone levels are increased. So again, which of the following is the most likely finding in this patient? Think about that. Think about how many steps it might take you to come to an answer. And as you do that, I'm going to pass it off to Paris. Paris?
Thank you, Jeff. So what we're going to do is, as Jeff mentioned, we're going to show you what we think are the important clues in this vignette and the lead-in. So starting off, generally, the first thing you're going to be given are demographics. In this case, it's a 17-year-old boy. So making note of that will really start to clue you in as to what things you should be thinking about, especially in a reproductive topic, right? Then they'll usually tell you, why are they coming to the doctor? Why are they coming to the clinic? And in this case, it's because of not developing signs of puberty as well as behavioral problems, okay? So that's also important to make note of, the behavioral problems as well. So you want to take note of those presenting signs and symptoms. And a lot of times they may tell you, how long has it been going on for? It's been going on for a few minutes, a few years, so you can get some degree of chronicity to those problems, okay? You can see there, they also told us some important other physical exam findings and then some laboratory findings as well. Obviously, as you can see there, those are going to be very important to coming up with an answer to this reproductive question. So this is now asking us, what's the most likely finding in this patient? Okay, so that's probably the most important phrase there, most likely finding, okay? So I think we've got a couple steps here. I think one, we've got to figure out what's going on in this patient, maybe what's the diagnosis or condition. And then two, what is a finding in that condition, okay? So I think we've got a nice two-step question here. So let's go ahead and let's take a look at those answer choices. And what we have here are 5 answer choices. And when we work with students, we recommend that students actually, as they're going through answer choices, that they actually start at the bottom and then work their way up to the top. So start with answer choice E and then work your way up to answer choice A. And the reason we do this is because a lot of times we'll see students who, they'll start at the top, they'll select something they like, but they won't have gone through all the answer choices. And so thus, sometimes they'll get that question wrong. So we recommend doing it this way to prevent yourself from making that mistake and to prevent yourself from biasing yourselves. So let's go ahead and let's do that now. Answer choice E, fibrosis of the seminiferous tubules. D, decreased gonadotropin releasing hormone, C, decreased follicle stimulating hormone, B, congenital adrenal hyperplasia, and A, cellular resistance to testosterone. So we're going to go ahead and open up that poll. Go ahead and select the answer choice you think is the most likely finding in this patient. Talk about it in just a few seconds.
Okay, thank you, Paris. So once again, the quick poll is up. Take a look at that. Take a look at those answer choices and let us know what you think is the most likely finding for this boy. Again, we're going to wait until about 2/3 of you have voted before we reveal the answer. So it looks we've got an interesting spread here. Looking at the progress so far. Maybe a few more seconds to register your selection. We always remind you that it's important to answer every question on step one. You are not going to be penalized, so there is no way that you should allow yourself to let a block go by without you answering every item. And we want you to answer every question here in Question Lab too. So, okay, it looks like, we've got a good voting percentage here. So I'm going to close the poll and let's share those results. And wow, we've got 4 candidates here that all received double-digit responses, including cellular resistance to testosterone, which was the leading vote getter, followed not far behind by decreased gonadotropin releasing hormone. Okay, interesting. So let us see what the actual answer is. I'm going to hide those results, and we're going to find out that the answer is answer choice E, fibrosis of the seminiferous tubules. That was the 4th leading vote getters. So it looks like there may have been a little bit of confusion here in this item. So don't worry about that. Paris is going to help clear it up. Paris?
Yeah, thank you, Jeff. Yes, definitely a nice, tough question here. These are some of those tougher reproductive questions that I know we all love. Okay, so let's take a look at this vignette again. So this is a 17-year-old boy. We're told he has gynecomastia, and we're told that he's got elevated LH and FSH levels, okay? He also has not developed signs of puberty and hasn't had testicular enlargement, hasn't had pubic hair, body hair. So this is probably suggesting hypogonadism, okay? And probably primary hypogonadism, okay? And the reason we can say that is because the pituitary function is normal, okay? There is levels of LH, there is levels of FSH. We know that it's not an issue with that not being produced. They are being produced. So in this case, it's probably more so the peripheral area, the peripheral aspect of it. So that would be primary hypogonadism. Okay. So in those situations, we often want to ask a few questions. Have you ever had radiation to the testes? Have you ever had chemotherapy? Did you ever have mumps? Did you ever have trauma to the area? Okay. Maybe they had cryptorchitism, okay, where the testes did not descend. And we're not really told about that, okay? So what we should be thinking about potentially in this patient is Klinefelter syndrome, okay? We're told that this patient has a very tall height for age, and on top of that, the gynecomastia, okay? So they're taller than expected, they may not complete puberty, okay? And they often have infertility, okay? The other thing that's important is that these patients often have learning or behavioral or developmental disorders, okay? Which is why it's important to make note of that clue in that first sentence, okay? So let's take a look at the next slide. Let's take a little bit of a closer look at Klinefelter syndrome. And you can see on this next slide that this is due to an XXY genotype. So a male, an XY who has an extra X chromosome or an XX with a Y chromosome, okay? You can see there that these patients often have testicular atrophy, tall stature, gynecomastia, and may present with developmental delay, okay? And you can see there that in the pathology, you have dysgenesis or issues with the seminiferous tubules, okay? So because of this, because you have the decreased seminiferous tubules as well as decreased Leydig cell function, you lose that negative feedback. So now your FSH and LH levels are going to rise, as you can see there on the right side of that column, okay? This is consistent with what our patient had, okay? So let's go back. Let's take a look at our question, our vignette. Hopefully now you guys are able to see how this fits with Klinefelter syndrome, okay? If you picked some of the other answer choices, let's go through those. So decreased GnRH. This is more so consistent with Kallmann syndrome, Kallmann syndrome, where you have delayed puberty, but you also have other things like impaired sense of smell. Nothing we're being told about that. Decreased FSH. Well, we already are told that the FSH levels actually increased, so that doesn't really make sense, okay? Answer choice B, congenital adrenal hyperplasia. This is a genetic deficiency that can lead to, there's obviously a few different types of CAH, okay? Most types of this that actually result in virilizing issues. So females actually have more male appearing genitals, okay? However, you can have a male patient appearing with female genitalia in 17-alpha hydroxylase deficiency. That's a type of congenital adrenal hyperplasia, okay? However, the issue is this patient would have hypertension, high mineralocorticoids, nothing we're told about in this patient. Then lastly, cellular resistance to testosterone. This is getting at androgen insensitivity syndrome, okay? And this is when male patients, 4 to 6 XY patients, are insensitive to androgens. So they have high testosterone levels. So they appear female, okay, but they have female external genitalia. They would have a blind vagina. They would have undescended testes. Nothing we're told about that fits with that in our patient. So a little bit of a different answer choice. All good things to be thinking about, but there are some important and subtle clues here in this vignette that point us more towards Klinefelter syndrome. So definitely a tough question, but a good learning point for today as well.
Excellent. Well, thank you, Sean or Paris. That's I think quite a few good learning items there within those distractors. So, okay, we've got one down. That was a challenging one. Let's see how everyone does as we go forward here, and we are going to tackle question number 2. Now, again, we're going to start by reading the lead-in first. Which of the following structures would most severely disrupt blood flow to the ipsilateral ovary if severed during this patient's surgery? So that's the lead-in. Let's read this quick vignette. A 42-year-old woman with pelvic pain is diagnosed with uterine fibroids and undergoes elective hysterectomy. Which of the following structures would most severely disrupt blood flow to the ipsilateral ovary if severed during this patient's surgery? Think about that as, again, how many steps you might need. And I'm going to pass it over to Paris. Paris?
Thank you, Jeff. So yes, definitely a shorter question here, but you can see that this is kind of an anatomy question. We know in our reproductive section, there's a lot of anatomy that's very important and that can also be tough, right? So let's take a look at this question. We're told that this is a 42-year-old woman who has fibroids and is getting a hysterectomy. So those are, I think, really the only important clues you need from that first sentence, okay? But the question is really what's important. What structure would most severely disrupt blood flow to that ovary if severed during the surgery, okay? That's really the main crux of the question here, okay? So let's take a look at our answer choices. And once again, I believe we have 5 answer choices, okay? Once again, we're going to start at the bottom and we're going to work our way up to the top. Answer choice E, suspensory ligament. D, round ligament. C, ovarian ligament. B, broad ligament. And A, cardinal ligament. So we're going to go ahead and open up that poll. Go ahead and select the answer choice you think is the best answer, and we'll talk about it just a few seconds.
Okay, we are going to launch this this poll here in just a minute, but take a good look at that lead-in. We do have to we had to shorten the lead-in just because GoToWebinar does not allow a question that long. So we're going to go ahead and get this launched. So again, the full question is, which of the following structures would most severely disrupt blood flow to the ipsilateral ovary if severed during this patient's surgery? Think through that as we go through here. We've got looks like about a third of you have made your selection. You do find this on USMLE and on NBMEs. Sometimes you'll see some of the questions with shorter and more focused stems. Stem length, definitely can go right across the board, but you are going to be hit with a few of these where you really need to make, you don't have a whole lot of information to draw from. Okay, looks like 3/4 of you have answered, so I'm going to close the poll. And let's go ahead and share these results. And looking at it, again, we don't have an overwhelming favorite here. It looks like suspensory ligament received the most number of votes, with broad ligament in second place. But again, all of the answer choices here received double-digit votes. So be interesting to see what the answer is. So I'm going to go ahead and hide the results and reveal the answer. And the answer is suspensory ligament. Yeah, it looks like many of you were on the right track here. So for those of you who weren't or may have gotten confused, again, it's okay to miss them during question lab. The point is that you're going to get them right on test day. And to help us with that, I'm going to pass it over to Paris.
Thank you, Jeff. So let's take a look at this question. Nice job here. So this question was asking us about a structure that would disrupt blood flow to the ipsilateral ovary if severed, okay? So we want to be thinking about the ovarian vessels that would disrupt blood flow to the ovary, okay? And what structure is that contained in? Well, let's take a look at the next slide, okay? If you take a look at the next slide, you can see on both of those images, you can see the ovary, okay? And you can see connected to the ovary is the infundibulopelvic ligament, okay? That is another word for suspensory ligament, okay? And in that infundibulopelvic or suspensory ligament are our ovarian vessels, okay? Let's take a look at the next slide. And this is a really nice table in first aid that goes through some of these important reproductive structures and all these various ligaments that they talk about. And I know how confusing they can be, so it's important to try to make sure that we understand which ones are which. So as you can see there, the very first one is the suspensory ligament or the infundibulopelvic ligament. And this contains the ovarian vessels, Okay, so injuring this can cause damage to that, which would cause disruption of blood flow to the ovaries. The cardinal ligament contains your uterine vessels. So if you were to have damage to this, you would have disruption of blood flow to the uterus, not the ovary. Okay. The round ligament of the uterus is a little bit different. This is actually more so just a derivative of that gubernaculum. Okay, not really containing any vital structures per se. The broad ligament, as you can see, they're kind of a big fold of peritoneum, okay, that contains a lot of those various solid organs, the uterus, the ovaries, okay. And then the ovarian ligament, once again, this is also just a little bit of a remnant, a derivative of the gubernaculum that just kind of attaches to the uterus. So if we take a look back at the anatomical pictures, let's take note once again of our infundibulopelvic or suspensory ligament, and you can see there how it's attaching to that ovary. So it makes sense that it would have those ovarian vessels. Okay. Now make sure we're also pointing out the cardinal ligament, and that's kind of in the middle of the screen, kind of at like 5 o'clock. That cardinal ligament you can see is containing those uterine vessels. Okay. And that would be important if you were to damage that to causing uterine blood flow. Okay. So hopefully you guys kind of understand why that's the correct answer here. We kind of walked through the other answer choices and what those contain. So great job on this question.
Yeah, definitely. Thanks, Paris, for the breakdown. Again, good and important anatomy question here. And especially if it's been a while since you've been, really focused on reproductive anatomy. There's a lot that you're going to need to be able to remember and understand on test day. Okay, let us go back to my pointer. And we're going to get ready for question number 3. But first, I just wanted to remind you that our RX Question Lab is brought to you by RX Coach. For this is, I want to say we're getting close to holding our 100th question lab. I think it's coming up maybe this month, but we've been doing this since the beginning of the pandemic, and RX Coach has now been around for about 3 years, serving students just like you who are looking to perform well, whether it's on their boards, on their NBMEs, maybe they've got school exams. And again, for us, it's really about making sure that we understand where you're at, right? We do have a program, we do have a methodology, but it's important for us to understand where you're at. So, we begin our engagement with you with a 160 question assessment, and we evaluate that to see, where your strengths and weaknesses are, and we use that information to help sculpt a personalized study plan. So, with RX Coach, it is a one-on-one approach, and you're going to be working with one of our RX certified tutors, and you also get access to RX 360 Plus and RX Bricks, and that's important because our coaches are able to assess your progress, help walk through recent quizzes and tests, again, just to make sure that we're doing everything we can to help you be prepared on test day. So if you want to set up a free consult to see if the program is right for you, go to rx-coach.com and put the link in the chat. So check it out. Okay, let's go ahead and start question number 3. So again, we are going to be tackling 4 questions tonight, so we're halfway home. And let us reveal the question. And again, we're going to start with the lead-in. Which of the following additional findings is most likely in this patient? think about that lead in and think about what kind of data you might be looking for as we read the vignette. A 24-year-old prima-gravid woman at 8 weeks of gestation comes to the physician because of severe nausea and vomiting for the past 9 days and a 3-kilogram weight loss. She denies recent sick contacts. On examination today, her weight is 45 kilograms, 45.5 kilograms, and blood pressure is 110/70 supine and 90/60 standing. So again, which of the following additional findings is most likely in this patient? Think about that as we pass it over to Paris.
Thank you, Jeff. So once again, we're going to go ahead and show you what we think are the important clues in this vignette and the lead-in, okay? And so now, we're getting a little bit back to the OB section of reproductive, and we're being told that this is a 24-year-old prima-gravid woman who is at 8 weeks of gestation, and she's coming in because of nausea and vomiting, and they do give us a little bit of chronicity, 9 days, okay? We're also told a little bit about her vital signs here as well. We're told a few things here, okay, but kind of a short clinical vignette. But they're asking us, what's an additional finding that's most likely to be seen in this patient? Okay, so those are probably the important phrases there. What additional finding would we most likely see? So let's take a look at those answer choices. Let's see what we're working with. And we probably have 5 answer choices here again. Once again, we're going to go ahead and start at the bottom and work our way up to the top. Answer choice E, urine ketones. D, proteinuria. C, metabolic acidosis. B, low serum aldosterone levels. And A, hyperkalemia. So we're going to go ahead and open up that poll. Go ahead and select what you think is most likely an additional finding in this patient. We'll talk about it in just a few seconds.
Okay, let's see what you can do with this question. Again, which of the following additional findings is most likely? Always challenging because this is one where you need to to prioritize. One or more of these findings may appear, right? That you may expect to see, but which of them is most likely? So let's see. We've got about a third of you who have voted. A little bit slower on the draw for this one, so I don't know if some of you are wrestling between 2 of these answer options or not. Looks like it's an interesting split. It looks like we've got one clear leader and 3 that are really fighting for second place. So give you another 5 seconds here, and then we're going to close the poll. Three, 2, 1, and we're going to close that poll, and let's share those results. Okay, so a little over a third of you thought that urine ketones would be the most likely additional finding, but some of you were thinking hyperkalemia, some low serum aldosterone, metabolic acidosis, so quite still a bit of a spread. So let's go ahead and hide those results and share the answer. And the answer is answer choice E, urine ketones. So again, that the leading vote getter is correct. So if you didn't get that one right, no biggie. Again, you're not being penalized here. In fact, you're going to be rewarded with a rich explanation from Paris. Paris?
Well, thank you, Jeff. Appreciate that. So absolutely, you guys nailed it again. This is urine ketones, okay? So they're trying to get you here with a lot of those other answer choices, okay? Metabolic acidosis, protein in the urine, potassium aldosterone changes. The most important thing here is that this female patient has been throwing up for 9 days, to the point where she's actually lost 7 pounds, okay? because of that, you can see that she's actually orthostatic. Her blood pressure drops greater than or 20 to 10 when going from a sitting to a standing position, or actually supine to standing position. Okay. So because of that, we know that she's lost a lot of fluids and she's very dehydrated. Okay. So because of this, this is a condition when in pregnancy, we would call this hyperemesis gravidarum. Okay, so a lot of nausea and vomiting in the setting of pregnancy. Okay. And these patients often show ketones in their urine due to the lack of food intake and persistent dehydration and vomiting. Okay. Now the other answer choices are probably incorrect, and we'll talk about that why. So proteinuria, that would be something we'd see if we were talking about maybe eclampsia, okay, or preeclampsia. Okay, not necessarily what we would see in just plain vomiting. Metabolic acidosis. Now remember, vomiting actually raises your pH. So if anything, it would be metabolic alkalosis, not acidosis. Aldosterone levels. Once again, vomiting, if we're getting rid of fluid in our body, that would actually lead to a higher aldosterone level to try to retain more fluid and sodium. Okay, so the opposite of answer choice B. And then lastly, hyperkalemia. Once again, vomiting, if anything, would lead to a hypokalemic state. So the opposite of that answer choice. Okay, so the best answer choice here is urine ketones. So nice job on this question as well.
Yeah, nice work, everybody. Again, really have to kind of think through what those exam findings, what those lab findings are telling you about the type of patient that you're working with, what that diagnosis is, and how to figure out what else you would expect. So, good job, everyone. We're going to close out strong here with question number 4. So again, this is our final question of the night. We do have a raffle at the end of the evening, and you do need to be present in order to participate. So with that, we are going to once again start with the lead-in. Which of the following is most likely to be seen in this patient? Okay, another most likely question here. So you've got your antennae up as we go and read the vignette. A 52-year-old woman comes to the office for an annual examination. She is clinically obese, nulliparous, and still menstruating. Physical examination reveals a red, scaly patch on her right nipple and palpable axillary nodes. Palpation reveals a firm mass in her right breast and serosanguinous discharge from the right nipple. Which of the following is most likely to be seen in this patient? So think about that, how many steps it would take you to reach that conclusion. Let us know in the question box how many steps you think it is while we pass it over to Paris to help break this down.
Thank you, Jeff. Yes, a nice other big topic within the realm of reproductive are breast masses and breast lesions, okay? So we're being told about this lady who's a 52-year-old female, okay? We're told about some important risk factors. She's obese, she's nulliparous, and still menstruating, okay? Then, as we know with these breast masses, the physical exam findings are going to be very important, and they tell us about some of those things. Okay, so we want to make note of that, so that we can come to that diagnosis as best as we can. And then this question is asking us, what's most likely to be seen in this patient? So, I think 1, we've got to figure out what is the condition, what's the diagnosis here. And then 2, then we've got to figure out what else would likely be seen in this patient. So I think a nice 2-step question here. So let's go ahead and let's take a look at those answer choices. Once again, we'll start at the bottom and work our way up to the top. Answer choice E, solid pattern with central necrosis. D, lymphocytic infiltration. C, linear cells within breast stroma. B, large cells with clear halos. And A, fibrovascular structures lined by ductal epithelium. So we're going to go ahead and open up that poll. Go ahead and select the answer choice you think is the best answer here. We'll talk about it in just a few seconds.
Okay, everybody, this is your final question of the evening. So let's do our best to close strong. Think through this this particular question and see if you can reach the correct answer. Let's see, we've gotten about almost a third of you have voted. Votes are pouring in. Okay. Let's see, almost 2/3 of you have voted, so I'm going to give you a few more seconds. Once again, you know, you never want to leave a question unanswered on test day, and let's start building some good habits by making sure that you're answering every question in Question Lab. Okay, 5 more seconds. And we're going to close the poll. So let's take a look here. We got an interesting one here. You know, we haven't had any items tonight where there's been a clear and overwhelming favorite. So in this case, you know, we've got 2 answer choices that were kind of, you know, battling for top position: fibrovascular structures lined by ductal epithelium and lymphocytic infiltration. But then we also had a couple of questions that both garnered 15% of the vote. So that is, you know, good, an interesting spread. So we're going to go ahead and hide those results and let us see what the answer is. And the answer is answer choice B, large cells with clear halos. So that was one of those 2 answer choices that only got 15% of the vote, but turned out to be the correct answer. So that was a tough one. So we're going to need Paris to help us understand what happened. Paris?
Yeah, thank you, Jeff. Yes, definitely a tough question here. So let's take a look at this question again. And this is actually something that we see in dermatology a lot. As you can see there, you know, they do talk about a red scaly patch. Sometimes they'll call it a red eczematous patch, okay? And in this setting, this is actually something pointing to a diagnosis of Paget's disease of the breast, okay? So Paget's disease of the breast usually presents with a unilateral eczematous or kind of red scaly patch on the nipple, okay? And whenever we see that in dermatology, we often know that we need to biopsy it and we need to look for an underlying malignancy in the patient, okay? If we take a look at the next slide, this is what you would see on histopathology of that biopsy. You would see these prominent cells that are surrounded by a little rim of space, what we call a halo, okay? This is what we'd call Pagetoid spread, okay? You can see this in a few things: Paget's disease of the breast, melanoma, a couple other conditions as well. But when it's on the breast like this, definitely consider Paget's disease of the breast, okay? And these are what we would call those halos. You can see not just the one that arrow is pointing to, but kind of all throughout that whole purple epidermis, you can see a lot of other cells that kind of have like a translucent halo around it. These are all halo cells or Pagetoid cells, okay? If we take a look at the next slide, this is kind of talking, this is a table in first aid that talks about Paget's disease, okay? And so basically what it's saying is you have an underlying breast cancer that has worked its way up and extended now onto the skin. And it presents as like a patch of eczema over the nipple or the areolar skin, okay? And those Paget cells are bad cells. They're cancer cells, but they're within the epidermis of the skin, okay? And those Paget cells are surrounded by those halos, okay? And that's what we call Paget cells, and that it would be consistent with the diagnosis of Paget's disease of the breast. Okay, so if we go back to our question, we can see there that that really important clue was that red scaly patch on the right nipple. That's probably the most important clue in that vignette. That really is going to point you to Paget's disease. Okay, now the other answer choice is answer choice E. That would be talking about like a comedocarcinoma, okay, not what we have going on here. Lymphocytic infiltration would be more of like a medullary carcinoma, not what we have going on here. Linear cells within the breast stroma, that would be more like a lobular carcinoma. And again, remember those are usually bilateral, and again, a little bit different. We wouldn't really have that red scaly patch. And then lastly, answer choice A. This is something we would see with like an intraductal papilloma, which is something usually more of like a bleeding lesion or lesion just underneath the nipple, once again without that red scaly eczematous patch. So always keep that on your differential. If you ever in the future see a little patch of eczema on the breast or near the nipple, always make sure that you're working them up and considering a biopsy. And working up for an underlying malignancy at the breast. So great job on tonight's questions, you guys. And I will hand it back to you, Jeff.